for several years in areas of healthcare, bargaining for health insurance, legislative strategy. The way I describe Cindy is she knows all the shenanigans the employers are trying to do to get as much out of you to pay for your health care. So she knows all the employer shenanigans and can advise us on the best way to bargain for health care, how to investigate the different healthcare offerings that you have from your employer, and how to get the best that you can get in this patchworky system that we have. And then she has some thoughts on other solutions to the problem that would make healthcare a lot more affordable and accessible for all of us. So with that, I'm going to turn it over to Cindy.
Thank you, Jerry, and thanks, Simone. The nurses are the guardian angels of an evil healthcare system. So for you nurses that are on this Zoom today, thank you for getting on, and I am so grateful for your service and what you do for patients. So I just want to reiterate what Jerry said about the training. It really is, Ron's popped up our agenda today, and I want to introduce Ron. He's the moderator for this Zoom session that works for me and moderates my Zooms. And any questions that you have, if you can put them in the chat box, there's Ron right there. You can put them in the chat box, and Ron will call them out to me at an appropriate time. Or actually, let's just stop as we go along. I think it's a better way to do it, Ron. If someone asks a question, just interrupt me and get me to stop so I can answer it as we're moving along.
Okay.
And he's gonna keep the slideshow going and get the videos up that we've got going. So I just want to say this is our agenda for today. We're going to talk about, patient or employee fees. This is kind of what you pay to access the healthcare system. We're going to talk about different plan designs, the actuarial value. This is how you can actually do an apple-to-apple comparisons of the plans that are offered to you. We're going to talk about the various financial vehicles that are available to you, like an FSA or an HSA or an H.E.R.E, some of those, so you get a little bit of knowledge of that. We're going to talk about preparing for 2020 and beyond, and the new trends, tricks and trends that employers often do to get you to pick the lowest cost health plan for them, not necessarily for you, and then open it up for Q&A. But again, because we're such a small group this afternoon, let's just ask questions as we go along and make this casual and comfortable for you. And also you should have gotten some handouts in advance. So if you haven't received that, let us know and we'll get those to you so that you can have that little bit of background information that'll also help you. So next slide, Ron. So I have been showing this chart since 1984, and the Kaiser Family Foundation, which is not in any way attached to the Kaiser Health Plan. This is really a separate entity that produces lots of healthcare policy. Every year comes out with this new slide about how much healthcare costs and how much family premiums or employee premiums have gone up. And one of the most instructive things about this slide is you can see how deductibles have gone up, in the last 10 years, 111%, which means that you're paying, as an employee, you're paying more out of pocket because the deductible is more expensive. You can see how family premiums have increased 55%, and then overall inflation, right, is right at 19%, and then workers' earnings. And you can see that healthcare inflation and our premiums are going up much faster than our wages. So as the price of milk goes up, the price of college tuition goes up, the price of housing goes up, it's not keeping up with healthcare inflation. And so oftentimes every ounce of blood that we can drain from that employer turn up ends up going to pay for those increase in health insurance premiums. And it's actually really impacting our quality of life and our standard of living because there's no cost control on health insurance premiums. Next slide, Ron. So, the problem is that we treat healthcare as a consumer good in this country, just like buying a new cell phone or a pair of shoes. And the industry continues to blame patients and providers on the cost of care with excessive regulations and, and oversight and, consumers, if they just become a little smarter consumer of healthcare, they would be able to control the cost. But it's because we treat healthcare as a consumer good and not as a human right. And that's the environment that we're dealing with. So with that in mind, we have to be smarter and we have to be more prepared than as we're in this environment to pick the best plans for our families so that we get some good value out of this health insurance system. Next slide, Ron. So we're going to start out with some really basic concepts. These may be things that you know, but I think it's just important to recap them so that everyone understands, kind of what your fees are. So if you can pull up the next slide, Ron. So this is really basic. I've listed the fees out in 3 separate pieces. A co-payment, co-insurance, and a deductible. So a co-payment is a defined amount that you pay for a specific service, like a $10 co-payment or a $20 co-payment for an office visit. Co-insurance is a percentage of the cost. So let's say you have someone might say, I have a 90-10 plan or an 80-20 plan. The 20% is your share. And that's called 20% co-insurance, and the employer plan or the insurance plan would then pay 80%. And then the deductible is the amount that you have to pay upfront before your insurance plan reimburses for anything, with the exception of preventative care, which is covered at 100%. So next slide, Ron. So I want to talk a little bit about the out-of-pocket maximum. Is the when you look at you could look at your summary benefit coverage, or perhaps your employer provides you with some type of explanation of the plans that they offer. But in some of the information that you're receiving, and we also do spreadsheets that have this information on it, you're going to see an out-of-pocket maximum, which is the maximum that you or your covered family members has to pay for covered services. And this includes co-payments, the deductible, the co-insurance. But if you're paying a payroll deduction for your share of the premium, the out-of-pocket limit does not include that. So when you're thinking, let's say you have a $2,000 maximum out-of-pocket limit per year, whatever your share of the premium cost is that's coming out of your paycheck is not included in that out-of-pocket max. And I also want to tell you that the insurance companies do not keep track of this. You need to keep track of it, and unfortunately that's the truth. I had an experience where I had a $225,000 medical bill, and grateful to have insurance. My maximum out of pocket was $1,500, and when I reached that, UC Davis, which is where I went for medical care, continued to bill me. And so I had to call my insurer, which was Anthem Blue Cross, and say, I have paid $1,500. That's my out-of-pocket maximum, but I'm continuing to get bills from this for this medical hospitalization I had. And they said, oh, we're sorry. We now see that you've paid your maximum. So when you get that, when it comes January 1st, you take every EOB, the explanation of benefits that you have, and you put it in a file, and you keep for you and your family, and you keep that for the entire year through December 31st, so that you know if you've reached your out-of-pocket maximum, you can call Health Partners or the other administrator and say, I've reached that. When it gets to be December 31st and you're going to start the new year, then just take all those EOBs and throw them in the shredder so that you take care of that private health information and make sure it's shredded. And start again with the new year. So next slide, Ron, please. So I'm just pulling this spreadsheet up to just kind of show you the highlighted in red are examples of the out-of-pocket cost. The deductible on this slide is in the first row. So you can see, right here where it says deductibles on line 1, you can see a $300, $900 in-network deductible. And then that's the amount you pay before the insurance company pays for anything with the exception of prevention. And then you can see on here the out-of-pocket maximum on line 2, right on here. And then when you get to line 4, you can see the copayment, right? I just wanted to illustrate for you. This is a spreadsheet that we did. I think this comes from Alina a few years ago that I developed this slide from. But you can see how, these are your share of costs. You can see what it would look like on a spreadsheet. So again, deductible is usually paid up front first before prevention. Out-of-pocket maximum is your maximum liability. And once you reach that point, you shouldn't have to pay for anything else other than your monthly premiums. And then the office visit copayment is a defined amount, a $10, a $25. You can see on here what the red looks like. Those are the employee's share of costs. So next slide, Ron.
Cindy?
Yeah.
I'm sorry, we're getting some background noise. It sounds like maybe some rustling of papers next to a microphone or something.
That's me. I'll move them.
Oh.
That's my notes, Jerry. I'll move them
Okay,
back away a little bit. Yep, you bet. Thank you for telling me that. So this next slide actually demonstrates a nuance that is becoming a trend. And as you can see, we've highlighted here the in red, you can see $1,000 RX maximum out of pocket and a $3,500 for medical. So what employers are doing now to lower premiums is they're shifting more of the costs onto employees and onto nurses by creating 2 separate out-of-pocket maximums. So when you get into bargaining or when the employer says, here's your new plan choices, you want to see if they're separating out those out-of-pocket maximums between the pharmacy and the medical, and because that means you'll be paying more than in coverage. It's a cost shift instead of a cost containment measure. So next slide, Ron. Whoops, can you back up for just a second? Okay. Oops, here we go. All right, next slide, I got it now. Prior to the Affordable Health Care Act, there was really no way to evaluate how plans compared with each other. There was no real measure of the value of the plans. And so oftentimes as a consultant, I would go in and I would provide comparisons to the employer and the union. And I would say, I would even do a little highlight of the differences in the plans. And oftentimes employees would get fixed on, I'm going to get an increase in the copayment of my emergency room. And I would often say, yes, but you're going to get a reduction in your copayment on prescription drugs. And so when you're doing a plan comparison, it all depends on where you're sitting in the world and the composition of your family and their medical needs. But there was never really like a way to do an overall evaluation of what plan was better than the other. And a component of the Affordable Health Care Act was to assign an actuarial value to each plan that's offered. And it's not a perfect measure. It's a measure that's based on the 10 essential benefits of the Affordable Health Care Act, but it's the only measure that we have. And it's the first real measure that we have that you could look at 4 different plans and say, here's the plan that provides the best level of coverage, and here's the plan that provides the least amount of coverage. And that's called the actuarial value. And Ron, if you'll move to the next slide, I'll kind of show you what it looks like. So this is a spreadsheet that we did for Children's Hospital a few years ago. And if you go all the way down to the very bottom of this slide, you'll see a big red arrow that's pointed and it says 91.19%. So in this slide, with this arrow, you can see that the care plan that Children's offers to its nurses has a 91.19% actuarial value. And what that means is, on average, the insurance plan is going to pay 91.19% of the bill, and the nurse is going to pay the remainder. So let's just say 91% just to round down. So if you were enrolled in the care plan, on average, the plan would pay 91 cents of every dollar, and you would pay 9 cents of every dollar, or the employee would pay 9 cents of every dollar. And if you go to the next plan, which is the Children's choice plan, what we call choice, it's 84, let's just say 84%, because we're going to round. And then the nurse would pay the 16 cents, right? The difference on average. And so when you look at a spreadsheet that we do, you can look at that actuarial value and say, here's the plans that provide the greatest value to me, which are usually a little more expensive. And here's the plans that have the least actuarial value, which are probably a little less expensive, except that you pay more out of pocket when you have a plan that has less value. So you really have to kind of think, how does my family use healthcare? Do I have family members that are ill? Do I have children that I know are gonna, well, if things were regular, that are gonna fall and break bones and get scrapes and colds and things like that. So, but this is a tool that we offer, that we do for M&A, that allows then the nurses to be able to look at their own health plans and know how each compares to the other. And at the bottom of this that you can't see, we also put the employer and employee premiums, so you could see what your share of cost would be. Usually those are done on a bi-monthly basis. So any questions on the actuarial value, or does that make sense?
Yes, this is Cassie Hamilton. One question I had was, so the actuarial value, does that actually take into account the premiums as well, or is it simply just the plan itself?
It's just the plan itself, Casey, and it's based on the 10 essential benefits of the Affordable Health Care Act. So things like chiropractic coverage is not included in the actuarial value. And in one of the handouts that you should have received, I provided a little bit of background information about what the actuarial value is and the 10 essential benefits that the actuarial value is based on.
Okay, and is there a way to find out, like, if someone's getting insurance on the marketplace, how to find out what those are?
They should actually. The gold plan is 90%. Do you guys have the these metal tiers that have been assigned to the marketplace? I think you do. They've got like a gold plan, a silver plan, a bronze plan, and a platinum plan. If not, you could call your insurance exchange and ask them which metal tier is assigned and which actuarial value, because they have there's regulations that they have to offer, the platinum, the gold, the silver, the bronze. There's 4 metal tiers that they offer, and they are assigned an actuarial value. Did that answer your question?
Yes, thank you.
Okay, good. All right, so next slide, Ron. So I'm going to talk a little bit about financial vehicles. There are 3 common financial vehicles used to access pre-tax dollars for eligible benefits, and all have different features. We're going to watch this video, which is going to kind of lay out, the key components of a health reimbursement account, a health savings account, and a flexible spending account. And then I'll see if there's any questions after that. So Ron, go ahead. I see you've got the video pumped up here.
FSA, HSA, H.E.R.E. That's a lot of letters, but what do they mean? Flexible spending arrangements, health savings accounts, and health reimbursement arrangements are types of accounts established to allow employees to pay for certain qualified expenses. Contributions are pre-tax and reimbursements are not taxed. The only catch is that those reimbursements must be for qualified medical expenses. So how do they differ? FSAs and H.R.Es are established and maintained by the employer, meaning that an employee's account is tied to the job. If employment is terminated, the employee forfeits the funds in the account. HSAs can be created by the employer or the employee, but may only be created to accompany a high-deductible health plan. HSAs are owned by the employee and are completely portable. FSAs and HSAs can be funded by both employer and employee contributions, but H.R.Es are only funded by the employer. All funds in H.R.Es and HSAs carry over from year to year. FSAs follow the use it or lose it rule, which requires that funds be used up by the end of the plan year. If they're not, the employee forfeits the money. As an option, FSAs can offer either a carryover provision or a grace period to help employees spend down their accounts. Unlike the other two plan types, FSAs can actually allow for 3 types of expense reimbursements: medical, dependent care, and adoption assistance. But separate accounts need to be established for each type of reimbursement. That's a quick breakdown of FSAs, HSAs, and H.R.Es. Want to learn more? Check out our e-learning courses.
Whoops. Can we get the slideshow back up? Thanks, Ron. So let me just say another word about this. You should have gotten a comparison that kind of compares all 3 of these vehicles that highlights what each offers and what the provisions are around carryover and other key principles of each one of these vehicles. But if you have any daycare expense, if you have a lot of out-of-pocket costs for medical, even some over-the-counter medications can be covered. So these can work to your advantage depending on your specific situation. So next slide, Ron. So preparing for bargaining, luck just doesn't happen with this. It really does require a lot of preparing, and we're just about through this, getting ready for the 2021 plan year. So every hospital that I've worked on in Minnesota, which I think is all of them by now, all the new plans and premiums start on January 1st. So we've been working with various M&A labor representatives to kind of bring that healthcare information and plan information up to date. So, what we do once we get the summary benefit comparisons and the summary plan descriptions, which are the legal documents of the plan, so that we can be sure we're providing you with accurate information. We can determine if there's any change in benefit levels. We can determine if there's any change in the delivery system. For example, my employer changed administrators and now my network is completely different. Or my employer is implementing a new narrow network health plan. We can identify those types of changes. We can review the renewal package, which is what the consultant, the employer's consultant, the hospital's consultant provides to them around the rates, and then any additional analysis that is needed. And that's a service that we offer to M&A as a component of our services. And we've really been able to drill down and find employers sometimes aren't properly funding their benefit plans. Oftentimes we've seen, I don't want to say a change enough to constitute a diminishment of benefits, but certainly some nuances that we can at least begin a discussion with the employer about the impact of that on the nurses and help move them in the right direction. So this is what we call how we start preparing for bargaining. And next slide, Ron. So one of the things that's really important to understand is, how is that premium rate built up? Like my health insurance, not just your cost, but let's say your cost and the employer cost is the total premium for the plan. And what are the building blocks to that? Like what's included in that? And all of this information is included what we call the renewal package. So each year, the employer's consultant, whether that be Towers Watson or Hayes Consulting Group, usually comes in with to the employer. Usually, if you have a January 1 plan year, they're delivering this in August before the beginning of the plan year. And everything that's on this slide is what's included. So the employer and employee contribution, because that's the total income into the fund, right? Or into the account for healthcare. And then, you know, the paid claims, what was paid out for medical services and for prescription drugs. And that should be split out. And then what are the fixed costs? So how much, you know, per person per head is the hospital paying for administration fees, for consulting fees, and PCORI fees, which are in a nutshell, they're ACA fees that have to be paid. And then stop loss insurance to protect those monies. Almost every plan that I've looked at in California is self-insured, so they have stop loss insurance to help them prevent any catastrophic losses. If someone has, you know, $1 million or $2 claim, they've got stop loss insurance. And then what we call a reserve, or incurred but not reported claims. And that's an amount, about 2.5 months worth of claims that should be kept in a separate account and adjusted each year, so that if the employer says, I'm all done with Health Partners, I'm going to move on to Blue Cross Blue Shield, they have enough money in an account to pay off those claims after they terminate coverage. Because if you go to the, let's say your plan ends in July, someone has a, you know, an expensive hospitalization in November, it's oftentimes January and February before those claims get reconciled, and yet they may be with a new administrator in January. So that reserve has to be kept and set aside to pay for those claims, those just in case claims. And it's about 2.5 months worth of claims. And we have, we caught a hospital this last year who just wasn't reporting to the consultant was just, the administrator was just not reporting to the hospital this IBNR amount when it's the employer's money. And so we said, hey, where is that money? And they said, oh, we forgot to put it in our report. And we said, well, we'd like for you to do that, so that we know that those amounts are properly funded and that that health plan is on good standing so that it can continue to provide good insurance to the nurses. So next slide, Ron. So this is getting to be a real trend, and it's something, you know, a nuance about working with hospitals and nurses. And I work with nurses all over the country. I work with California nurses, Florida nurses, New York nurses. And what we always see in their health plans is that the employer always makes its hospital system, whether that be Allina or, you know, Memorial or another hospital system, Sencha, they always want their hospitals to be tier 1. And now we're seeing them to even begin to get into narrow networks to say you have to go to particular doctors or hospitals for certain procedures because they're supposed to provide savings, and they'll say, and they provide better quality. So what we do and what we suggest you do is when a hospital tells you that a particular system provides better quality, there is this great website. It's MN Community Measurement is what it's called. Ron's showing you this website, and you can look up all kinds of things on this website. So Ron, if you'll go to the hot link up there where it says MN Health Scores, you can see that you can look up the quality of a clinic, the medical group quality and cost, and that's based on information that they have to submit to the state, hospital quality and patient experience scores, and the cost of services and procedures. So pull up hospital quality and patient experience, Ron, just so that we can show folks what that might look like. So you can scroll down and see, you can look up all of these different ratings for the hospital, and it will let you know. You can find a name by location, and you can see, you know, I've gone in with employers and said, you know, you said that you're putting this on your network because it provides better quality, but in reality, it doesn't provide better quality. So can you help us understand what criteria you used to put this particular facility on your network? And then what you find out, it's just because it's cheap. That's why it's on there, but sometimes it's not. So Ron, can you move to the next slide? Oops. There we go. So this is one of the, new trends that are going on. So it's always, we always want to trust but verify. So with the MN community measurement, we want to make sure that, if the hospital is putting a special provider on your network because they say it's better quality, just check it out or let us check it out for you. We could do that and create a little metrics for you that will help identify that. So one of the things that M&A asked us to do was to kind of talk about these new trends in bargaining that are going on. And I will tell you that it's not just happening to you. These are trends that are happening in the health insurance industry all over the country. And so these are trends that we see everywhere. Not just in Minnesota, but we certainly do see them in Minnesota as well. So the first trend, can you pull up the next slide, Ron? So we're gonna get a YouTube ready for you, but this is where a hospital is asking a nurse or asking a patient, this happened to me, actually, to pay in advance. So I had a surgery scheduled at a hospital. It was outpatient surgery. I had my finger operated on, and the hospital called me and said, your share of cost based on your plan, you need to pay us $400 in advance of the surgery. And I said, well, in reality, you really don't know how much I have to pay for this surgery because it's not over with yet. I haven't even had it. And what if there's a complication? Or what if I don't need something that you've included in this surgery? You can't ask me to pay in advance. And I pushed back, and they agreed not to pay. And I oftentimes will say things just to scare people. And I just said, I called Anthem, and Anthem said that I don't have to do this. And they said, okay, right? So it's just pushing back a little bit, because once you give them that money, getting it back, if you pay for more than what your bill, actually your share of costs are, it can be very difficult to get that money back. So I just want to show you some of the behind the scenes shenanigans that these hospitals actually do to patients. So Ron, can you pull that YouTube up? Thank you. All right, so I showed you this video simply to say, they really don't know what they're going to charge until you get done with surgery. So don't let the hospital make you pay in advance. Just push back. And I always say, I'll sign a financial responsibility. I will pay you whatever I owe you, right? Because you're obligated to pay that. But don't let them collect anything from you in advance. So what's the next best thing, number 2? Ron, can you move to the next slide? So the next best thing on number 2 is I'm using this flyer to just demonstrate the use of centers of excellence. And this is, I work with a lot of schools in California. And this is a benefit that's offered by the Self-Insured Schools of California. It's the largest purchasing pool for public school employees in the United States. It insures over 400,000 school employees and their families in California. And H.E.R.E Health is the company that CISC has contracted with to provide a centers of excellence for its covered members. They're using Scripps in San Diego as a centers of excellence, offering lots of incentives to participate. And CISC will pay for transportation, lodging, meals, stipend for the patient, your partner or a family member to go with you. And then they offer this concierge medicine, kind of help you get through this bureaucratic process. And there's no co-payment or no co-insurance. And they say it's the highest quality of care. So who wouldn't want to go to San Diego to La Jolla and have surgery, right? I mean, it's a beautiful place in the country. However, Ron, let's look at the next slide. So sometimes centers of excellence are centers of mediocrity. You can see that both of Scripps facilities in San Diego are rated B, not A. And they've got lots of other issues. So clearly this is, I've actually been in negotiations with CISC about this very issue, about the criteria that they use to establish a centers of excellence. So you want to go back to that in community measurement site that I gave you and make sure that you're not going to a center of mediocrity, but you're going to a center of excellence when you're taking a look at surgery, or if an employer has put a provider on their preferred list. So next slide, Ron. I didn't often disagree with this guy. I mean, agree with this guy, Ronald Reagan, but I will say he really did have this wonderful term calling trust but verify. And that's what we want to do with those insurance proposals and the information that the employer gives you. We want to trust but verify to make sure that what they're giving you is accurate information. So next slide. So I've just put together a list of resources here for you. All of these have publicly available data to use to check out the quality of care. So you've got MN community measurement, and we kind of went through that website a little bit. The Leapfrog group is another group of employers, other large purchasers that have come together to provide some quality metrics for hospitals. The Medicare Hospital Compare is probably the best. It's got the largest database of hospital quality measurement. And then the Lowen Institute, and they just added a new metric, which I think is nice, which is it uses civic leadership as one of its measures to measure quality, which is important for a hospital and a community. So next slide, Ron. Ideas that will, this is like the next best thing, number 3, right? Ideas that will spike rates in the long run or create what's called adverse selection in your health plan. And these are things that you really don't want to do, or it's going to make your rates spike. And that's providing any type of cash in lieu of benefits to allow someone opting out of insurance unless they have proof of insurability. So if I were covered under my spouse's health plan and I could show proof that I had insurance, then I could be allowed to opt out, but not just opting out, because what you find then is that if I opt out of insurance, I want to opt back in when I have a brain tumor, right? When it becomes really expensive to treat me, and I haven't been contributing, and the employer hasn't been contributing to the plan prior to me doing that, prior to me saying I want health insurance because I'm sick. So watch that and don't allow that in your collective bargaining agreement. Putting any benefit money on the salary schedule will absolutely create adverse selection because it shrinks the size of the pool, and set employer contribution rates to the lowest cost plan. And generally the lowest cost plans with the least amount of value are the health savings accounts. So you don't ever want to allow the employer to say, the HSA costs $400 a month for an employee, so that's going to be the maximum amount that we pay, because then everybody is going to be driven into that lowest cost plan, and anybody that is sick and needs more medical coverage for themselves or their family are going to take the more expensive plan, and that's going to make the claims balloon, and at renewal time it's going to stick out like a sore thumb, and then you have the employer starting to say, oh, that care plan that has the 91% actuarial value is costing us too much, right? And then they start creating a public campaign around that. So these are just these are the be careful things, right? And the things that you don't want to do in bargaining. So Ron, what's the next best thing, number 4, right? The next best thing, number 4, is all of this work on wellness. And I just want to say that I do a lot of wellness work in California, with California schools and some hospitals and nurses here in California. But this is not the panacea around saving money. So the wellness industry is thriving, and most large employers offer some type of wellness program, and options can range like from a gym discount program to offering on-site flu shots to your nurses, so you probably get those anyway, biometric screening, and other bells and whistles that get offered at the work site. And the conventional wisdom was that that these programs were going to save us a lot of money, right? But that's not necessarily the case. Can you move to the next slide, Ron? So it's barely moving the needle. This has become an $8 billion a year industry. And I just want to say there's nothing wrong with a wellness program. It's great for employees. It gives them lots of opportunity to access things on school, at work. not going to change behavior or motivation. That can be difficult, but some of it can be very helpful, like estate planning or healthy aging or getting, care for your elderly parents or other, stress management, things like that can be really helpful. Those workshops can help. So it's not a bad thing. It's just not going to move the needle on your premium costs. Next slide, Ron. So the next best thing that the insurance industry is pursuing is this thing called consumer engagement. And really what this means is what I call, or this economic term that's referred to as moral hazard. And it's the notion of value-based purchasing. And if you just had a little skin in the game, it's the economic theory. So it's moral hazard is like, if I give you something for free, you'll just keep using it because there aren't any consequences for over usage. And so a few years ago, I was at Essential Hospital in Duluth, and the consultant, which I think was Mercer, came in and said, the reasons the rates were going up 22% is because nurses are riding in ambulances to the emergency room. And I just thought to myself, nurses know what go on in emergency rooms. They are not riding in ambulances to get there, right? And it's because there was no, like if you go to the emergency room and they don't admit you, there wasn't a $100 or a $200 charge for that. And the consultant and the employer were trying to get the nurses to agree to that as a way to lower the premiums. So this is the economic theory that we're currently in around bargaining. It's like the employer feels like if you just had a little skin in the game and you became a smarter consumer of healthcare, you wouldn't be using it so much, which is the most ridiculous thing I've ever heard of in my life. It's like nobody goes to the doctor or the hospital because they want to. They go there because they're sick or they're concerned that they're sick or someone that they love is sick. So we just have to learn how to navigate in these silly circumstances that we're in. So the next best thing, Ron. So I just want to say we're not consumers, we're patients. So the latest study adds, to other evidence that consumers don't shop around for the best healthcare value when they're spending their own money. That's just not the case. It's if you're a sick cancer patient, you aren't shopping around for the least expensive plan. You're looking for a doctor that can heal you, right? And concerns have grown that patients with high deductible plans end up delaying care. So when you're looking at those choices and you're looking at a $5,000 deductible in that HSA plan and your employer is only putting in $650 a year, oftentimes people have to make an economic choice thinking, I don't have that additional, $4,000 to pay before I start getting treatment. So be very careful as you're looking at your health plan choices around these high deductible plans. Next slide, Ron. So, there's a big push for employers to push folks into these health savings accounts because it costs them less. The claims costs are simply less expensive because employees have to pay more before the insurance plan starting to pay. So HSA creates a horrible downward pressure against the plan with the most generous coverage. So we were looking at this at an insurance committee meeting not more than 2 months ago, and the employer was saying, look at the claims cost in the HSA plan. It's only X, while the claims cost in the CARE plan, which had a 91% actuarial value, is so much higher. And it's like, well, of course it is, because the coverage is more generous, right? So what they want to start doing then is tagging this HSA as the plan that everyone should enroll in. So I just want to caution you about that when you're looking at your health plan options. So next plan slide, Ron. The next best thing is moving from 3 and 4 tiered contribution rates. So if you 3-tiered rate is an employee plus one dependent and a family member. 4-tiered rates are an employee plus child or children, an employee plus spouse and family. So you can see that additional tier is added in. And every time you squeeze this balloon, it pops out the other end. So oftentimes, if you move from a 3-tier to a 4-tiered rate structure, you're going to see the employee and spouse paying a lot more, and you're going to see the employee plus child or children, those rates go down. It's not any cost savings for anybody. It costs what it costs to measure the plan or to pay for the plan, but it's just more fragmentation from the employer on the rate side. And you just want to, if it happens and you're just covering you and your spouse, it's going to cost you more. If you're a single parent just covering your children, it's probably going to cost you less. But this is a new trend moving from 3 to 4-tiered rates. So next slide, Ron. So this next best thing that's happening are this whole thing around surprise bills. And there's national legislation that's been proposed several years in a row that the Democrats can't get out of the House. ER physicians and anesthesiologists have become independent physicians and will not sign with an insurance company. So if you're scheduled for surgery and the anesthesiologist isn't on the Health Partners network, oftentimes people don't think to ask because you don't see the anesthesiologist until you're literally getting ready and prepped for surgery. And an ER physician, you seldom ask because you're in the emergency room because you're in an emergency, right? There's a big push to stop this surprise billing. All of a sudden you get a bill from the anesthesiologist and the health plan says it's out of network and you're stuck with the bill. So let's take a look at this. Ron, can you pull that YouTube up?
Paying for healthcare can be filled with unpleasant surprises that jack up your bills. Would you stand for that when buying anything else?
Let's see, one piping hot pizza made to order. That'll be $89.50.
What?
Sorry, can't do anything about it. Tony, your regular dough thrower, is not here today, so we had to bring in Craig. See, Craig's not on your approved list of pizza makers, so you'll have to pay extra for his services. Don't worry, he's an artisan. We take paper, plastic, checks, or money orders.
That's crazy.
Hey, can I have a large pie with pepperoni, please?
I'm sorry, we just updated our formulary list of toppings and pepperoni isn't on it anymore. If you want that, you'll have to pay extra or pick something else.
No, I want pepperoni.
Hey, it's your lucky day. How about Spam? Now that's on the list, and it's also a meat, I believe.
That's great. I don't want Spam.
Spam?
You said that before and I still don't want the Spam.
I'm sorry, but we just negotiated a deal from a new ingredient provider. Didn't you read the fine print in our monthly newsletter?
That's crazy.
That'll be $2.
Thanks.
Hey, can I get a plain size stew, please?
That'll be $10.
She just paid $2.
Yes, but you have a high deductible pizza plan. So you'll have to pay $100 in out-of-pocket pizza costs per individual and $500 per family before you get the discounted rate. Of course, if it's a pizza emergency, we could probably work something out. In that case, you'll just have to pay the difference between the in-network and out-of-network pizza maker's charge. So you'll only have to pay $4.
You're kidding me, right?
Come on, it was all spelled out for you when you signed up for our pizza plan during pizza open enrollment season.
That's crazy.
Yes, it is crazy, but it doesn't have to be. Join our efforts to stop surprise medical bills and share your story at endsurprisemedicalbills.org.
Thanks, Ron. So as I just mentioned earlier, this whole issue around surprise bills has become a huge hotbed of controversy. And certainly in California, we have tried now for 5 years in a row to pass a surprise bill. I could not get it signed by a governor, not even Gavin Newsom. And certainly the Democrats in our national legislature can't even get it off the floor. So there's lots of work. You just saw the YouTube by the Consumers union. And if something like that happens to you, there's a website there that you can share your story. That really helps move legislation so that people understand and our politicians understand the impact of surprise bills when you just don't have control over what happens. Oops, I gotta start my
Cindy, your
video.
camera's, there we
Yep,
go.
I just turned it on. Thanks. I just saw that. Thank you, Ron. This is the next best thing, number 8, which is, when you're in bargaining, the employer will come in and say, we need to reduce healthcare costs due to, and you can insert anything in there you want to. There's 107 reasons why they want to reduce cost. So we have to push back a little bit, right? And we did that in bargaining this last summer with several hospital systems. So, we asked them, what data do you have that that allows you to come to the conclusion that you need to increase co-payments or co-insurance, right? To change the plan design. Show us the data and information that made you make this decision, right? What claims data do you have that shows that rates need to increase? Let us take a look at that. What do you think this change will achieve? So if the employer is saying we think everyone should enroll in a health savings account, we can push back by showing them lots of data that's coming out now that's saying health savings accounts are actually bankrupting families. People are delaying care because they don't have that money to put up front to be able to pay for care until the health plan kicks in. And, just generally what data do you have that supports your assumption? And, or, is this just like, the last bullet, just to make a point of the last bullet, is this just a blip year? Is this just an unusual year, or is this a pattern? Because if it's just an unusual year, we shouldn't do anything until we get a few years of data to see if there's a trend going on. And we were actually able to push an employer back by finding out that this particular year just happened to be a year that rates went up unusual, and we pushed them back down to have to reduce the premiums a little bit because we want to get some data and information to see what it is that's really driving up the premium rates. So so, often these changes come from consultant gibberish, what I call consultant gibberish. And we've got H.E.R.E Financial, which does consulting in hospitals in Minnesota, and also Willis Towers Watson does a lot of consulting for hospitals in Minnesota. We have Towers Watson here in California. We don't have H.E.R.E Financial in California at all. But they do consult to at least 2 hospitals that we worked with this last year. And you can just see, I just pulled quotes off of their websites that, it's value-based plan designs, which means making you a good consumer of care that these consultants are pushing, right? And if you look at, by optimizing your benefit package, you can offer an attractive healthcare and financial options to everywhere. And all of those are code words for we're gonna make the employees pay more, we're gonna narrow the network so they have less choices, we're gonna fool around with the formulary on their drug plan to make the least expensive, not necessarily the best prescription drugs available. So that's where this stuff comes from. They're from these consultants because the hospitals really don't know that. And these consultants are very tied to the industry. So what we do is we push back, right? That's why M&A has us at the table. So next slide. So I don't know how many of you have this Alex tool or how many of you are on the phone or on this Zoom, but a few years ago, I went to Minnesota for 2 weeks, and I went to every Allina hospital in Minnesota. And we talked about the health plan that was available after the strike and answered nurses' questions. And in preparing for this, I saw that Allina was pushing this Alex tool to help nurses enroll in the health plan that was coming up. And I sat in my office for, in the evening, and I would, play with this Alex tool, and I would put in, it ask you what your family income is, what you and your partner or your spouse's family, and don't put that up yet, Ron, I'm not ready. What your income is, how many children you have, how often you think you might go to the doctor, all of these financial questions, right? Projections. And every single time, no matter what I put inside this Alex tool, it sent me to a Linus Health Savings account. And I just thought to myself, at some point in time, certainly not then, I've got to find more out about this Alex tool. So I did find out more about the Alex tool, and now I want to share that with you. So because Alex isn't just for Alina, although it's what they use. Alex is a tool that is sold to employers to get employees to enroll in health savings accounts. So Ron, can you play this now for us?
Hi, I'm Tom from Jellyvision, and as you can see, my arm is inside this box of African fire ants. Why? Because the world is a chaotic place, full of opportunities to make bad decisions. But today, the decision I need to make is which health plan is best for me, my arm, and my family. We created Alex to answer that question.
Hey, I'm Alex, your virtual benefits counselor. Are you married? How many kids do you have? You have any ongoing prescriptions?
See, through this unique Q&A interface, Alex gets to know each employee's situation and then explains only the information they care about.
Based on what you just told me, this plan might be a good fit. Let me show you one.
Our approach is based on over 2 decades of interactive design experience, a reliance on proven behavioral economics principles, our roots in the games industry, and a belief in humor and plain English, which is why Alex avoids the kind of confusing jargon that can result in shortness of breath or loss of arm feelings. We've been proven to actually change behavior. Alex is helping literally millions of employees every year in hundreds of the biggest and best companies across the US. Using Alex actually saves companies money. And we're not just talking about health plans. Alex helps people understand their retirement, how their short-term disability works, financial wellness, and a bunch of other stuff. Give us a call to learn more. Tell them Tom sent you. Tell them I'm downstairs in the studio, and I need an ambulance.
Thanks, Ron. Isn't that clever? That somebody thought of developing this tool that would drive people right to high deductible health plans with a health savings account. And that's exactly what happens. So I strongly encourage you not to use Alex because that's what it's going to do for you, is it's going to drive you to a health savings account, but to use empirical data, use our spreadsheets that actually give you, an apples to apples comparison so that you may decide that a health savings account is right for you. And if it is, then you should do that. But I just want you to be informed about your choice and know what your other choices are and what the costs of those are before you just let Alex put you in a high deductible health plan. So next slide, Ron. So the next best thing, number 9, is to get rid of paying for spousal coverage. In an attempt to shave off healthcare costs, employers are fiddling with spousal and partner coverage. This new strategy is to eliminate spousal or partner coverage if they have coverage through their own employers. So let's say I'm married and my spouse has coverage for himself and me, but I don't take his coverage, or he doesn't take his coverage. I just enroll both of us in my health plan through the hospital, and he opts out of his coverage. He just says, I'm covered. I don't need to take the coverage with my employer. So once employers find out about this, they are starting to pay claims as if your spouse or partner did have coverage and only become a secondary payer. So this is new. It is something that is bubbling up. I'm sure there'll be legal issues with this, but it has not come up yet. So just be sure that unless there is, something in your collective bargaining agreement that your employer, is to offer and pay for spousal coverage, they can do this. So make sure you have that protection in your contract that says, here's what the cost of, my employer offers coverage to the spouse, pays for the spouse, whatever the terms are, so that they can't get into this new arrangement saying, oh, I'm Cindy, I know that your spouse has coverage through his employer, and he's not taking it, so we're only going to pay 20% instead of 80% of the allowable services. So next slide, Ron.
Cindy, this
Yes.
is Cassie again. How do you know ahead of time if that's happening? Like, I'm just thinking about like my brother, for example, like his wife, she's in a different union. She's a housekeeper, not an SAU or anything. And so how would you know that they're going to do that or not?
I would send a letter of confirmation. Well, first I would look at the collective bargaining agreement and see what it said around who the employer is obligated to pay for. Like if it says the employer pays, 80, I'm just using this as 80% of the family premium, then that they're going to pay for spousal coverage because it's included in there. If it just says the employer pays for employee only, or the employer, offers coverage to the spouse, those kind of squishy terms, I would just firm it up by sending a letter saying, this is to confirm that, ABC employer also offers and pays whatever the percentage is of spousal coverage, just to do a CYA, just to cover your behind and make sure that if this comes up, you have protection. Did that answer your question, Cassie?
Yeah, thank you.
Okay, you're welcome. So here's the next best thing, number 10, and that is retail clinics. They're popping up all over the place. I've just pulled 2 articles out for you. They are not, the bad thing about these retail clinics is they're not regulated nearly as much as regular medical clinics are, and certainly not as great as outpatient clinics in any state, including Minnesota. And so they've become less expensive. They're like what they call minute clinics. I know the CVS has what they call a minute clinic. And there's all kinds of things that you would generally get in a more regulated environment. And this is one of the things that's going to drive down the quality of care and certainly drive down the cost of care because there's not as much regulatory oversight. So I don't know that there's anything that we can do about this other than, big legislation. And there's not an appetite for that right now, but this is a trend I just wanted to share with you. And I would be cautious about using these because there isn't any oversight and regulatory oversight around standards that keep us safe, keep patients safe. So next slide, Ron. So I just want to say I'm a single payer supporter. I've been a single payer supporter for 40 years. And I have continued to watch workers pay more out of their paychecks, have, less generous plans because bargaining for health insurance is a failed bargaining strategy. And that doesn't mean that we don't fight for the best health plan and the best health care that we can get. It's just that we can't win this at the bargaining table, right? No one would go in and say, hey, let's bargain our Medicare benefits. Right? And we'll decide how much the employer is going to pay, and we'll decide how much I'm going to pay and what the plan looks like, right? Medicare is the employer pays and the employee pays for the period of time that you work in your life. And when you turn a certain age, or if you become disabled, you get it. And the plan of benefits are designed by people who know a lot more about healthcare than I do, right? So I want to use this YouTube a little bit because it's a little bit dated, but it really is great at explaining what single payer Medicare for all is. So Ron, can you pull that up for us, please?
The United States is going through a political reckoning, with lots of ideas on how to reform or completely change the way people get and pay for health insurance. Many on the right want to move toward a more privately run system, with less insurance requirements on individuals, health insurance companies, and employers, and less government subsidies and funding.
We want all the providers of healthcare services, insurers, doctors, hospitals, everyone competing against each other for our business as patients, as consumers.
But Republicans are splintered on just how to roll back the government's role in individuals' healthcare, something that came to a head when 4 different plans failed to pass the Senate in July. The left, on the other hand, wants to boost those public government programs and coverage requirements to give more Americans health insurance.
Democrats believe that health care is a right for all.
One of their buzziest ideas is single-payer healthcare, where the government is the single payer that pays for Americans' health insurance through a tax-funded plan. Single payer is a type of universal health coverage. That's where the government ensures that every citizen has health insurance. There are lots of ways for governments to implement universal health coverage. At least 30 countries have some form of it. The way our system works right now, there are a good deal of Americans who don't have health insurance. In 2016, about 28 million, roughly 9% of the population, were uninsured. And those who are insured have to work with a web of private insurance companies, employers, hospitals, pharmaceutical companies, and government-funded programs like Medicaid and Medicare. Single payer would funnel all of those negotiations into one channel, where the government determines a baseline of health benefits that it will fund for everyone, and sets or negotiates the price for those benefits. Just like there are many ways to get to universal health coverage, there are also multiple ways to implement a single-payer healthcare system. Bernie Sanders and some Democrats are backing a Medicare for All proposal. This would expand Medicare, which currently pays for certain health services for Americans over 65 and those with disabilities, to all Americans. Polling shows that a majority of Americans believe that it's the government's responsibility to provide healthcare coverage, and a growing share of Americans support single-payer healthcare. Those in favor of Medicare for All say that the plan would lower prices for healthcare services and medicine across the board. Americans pay double what many countries with universal health coverage do on health costs, and many say that those costs would be lower if the government could bargain down or set prices. Conservatives are largely against Medicare for All because it would shift more costs and responsibilities to the government and away from the private market, thus requiring more tax dollars to implement.
Get Washington out of the business of being a nanny state.
They contend that it would take away individual choice in health coverage.
This complete government takeover of health care.
Although liberals who support the plan argue the exact opposite.
The choice they made is they want to get quality health care.
And many moderates say that the transition to a single-payer system would be tricky and could upend health insurance coverage if done too rapidly. But with public perception warming up to single-payer and more Democrats jumping on board, we could see more of these proposals in the run-up to big elections in 2018 and 2020.
Okay. So that just gives us a little bit about we guarantee healthcare for every worker by guaranteeing healthcare for all. So Ron, next slide. All right, so we're going to wrap up where we started, right? And I go right back to the slides that just so eloquently shows that bargaining for healthcare is a zero-sum game. And I strongly encourage all the nurses, and M&A has been such a great voice in the single-payer community around creating healthcare for everybody, not only in Minnesota, but in our nation. So I want to thank you for your attention today and your time. I hope this was helpful and beneficial to you. That's really what we're hoping for, is that this gave you some good information to help you make choices and become a better bargainer, not a better consumer of healthcare. And we've still got plenty of time for questions. So we'll open it up for questions. If you just want to put something in the chat box, or I think we're small enough, you can just unmute yourself and let us know your questions.
And question from the moderator, should we continue the recording or stop that?
I think you should continue it, Ron, until we finish. Thanks.
All right, this is Cassie. How do you respond when people say, like looking at the graph that you have up right now, well, yeah, of course it's gone up. That's Obamacare for you. That's made everything more expensive.
So here's what I would do, Cassie, is this slide goes back to 1985, and I will pull up the old slides and send them to Linda and ask her to send them out to you. You can see that long before 2000. Well, okay, so I mean, even if you looked at this slide, Cassie, Obamacare got implemented in 2014. right? But if you go back to when the Kaiser Family Foundation first started documenting these graphs, you will see that actually when Obamacare, leading up to Obamacare, rates went down because every time that the legislature says we're going to regulate the industry, they lower rates. I call it the Hillary Clinton effect. I don't know how many of you remember when Hillary Clinton was trying to do healthcare reform, and rates dropped significantly because the industry was afraid that they were going to get regulated. So they, lowered their prices, and then everybody thought, phew, we're okay. So I'll send the older slides. Just let me make a note for myself, and we'll send those to you. And you can, if somebody says, oh, it's Obamacare that did that, you can say, well, no, go back to 1985, and you'll actually see that it wasn't Obamacare that did that, that this has been going on for a long time. Any other questions? Anybody?
Okay, I got another one for you.
Good. No, I'm glad. Keep it going, Cassandra.
So can people who buy insurance on the marketplace, can they do an FSA or HSA, or what how do they how can they get money pre-tax to use for medical expenses?
So the bronze plan, so you have, in order to get a health savings account, you have to have a high deductible health plan. It has to meet the government's, every year the IRS adjusts the deductible amounts for health savings accounts because you have to have a high deductible plan coupled with an HSA to be able to participate in an HSA. So if someone were on the individual market were to buy the bronze plan, they could then go down to their bank and say, I want to open up a health savings account and put in pre-tax dollars to cover my health savings account. And then if they were to have a co-payment or, prescription drug co-payment or pay for that big deductible, they then could draw out of that health savings account. But in order to participate in that, you must have a high deductible health plan, and they offer those on the insurance exchange. It's called the bronze plan. It's the 60% plan.
So is there an option for an FSA if you are employed, but your employer doesn't offer health insurance? So you go to the private market, or the public marketplace?
Yeah, you can. It's tougher to do. It's generally an employer that offers an FSA, but you could check with your local bank to see if they'll allow you to open up an FSA account. But generally, that's offered more to a group market. I mean, to like an employer, it's an employer plan. There has to be an employer sponsor because they have to file 5500s. They have to file tax forms at the end of the year because it's taxes, right? I mean, you're not paying taxes on certain money that's being deducted out of your check. And so I would doubt that that can be done on an individual basis. I think that's a more employer offered benefit than it is that you could get individual, but I know you could do a health savings account as an individual. Any other questions? Anybody else? Well, I would very much appreciate if you would fill out the evaluation form so that we could get feedback. It's the only way we know if what we're presenting to you is useful and helpful. And if there's something else that you would like to have covered when we do this again, I would encourage you to include that on the evaluation as well. And again, thank you so much for your time today, Jerry. Thank you for inviting us. We always appreciate and enjoy the opportunity. Thank you so much.
Cindy, can I ask one more question quick?
Sure, Kathy, absolutely.
So I'm just trying to understand what options there might be with the FSA stuff to do pre-tax. Can you use it for, could your spouse take out an FSA money to use for your expenses if you're not on their plan?
So let me be sure I understand the question. I'm going to set up the scenario so I understand what you're asking me. So you and I are married, and I have the FSA with Kaiser Hospital, and you want to know as my spouse if you can take that money out, if you can claim against it. Is that right?
Yes.
No. I mean, it is, you would have to submit the expense for your covered family. So let's say, I'll just use this. Let's say we had children and you had a daycare expense, then you would submit the claim. And you have to sign it because you're the one that's covered. It's your money coming out of your paycheck that's funding that FSA. So your
claim for your spouse, right?
Right.
I've done that. So I've used my FSA to pay for my spouse's prescription.
Yes.
Yeah.
Yes.
But I have to submit it. He can't do it.
Correct. Yeah. Thank you, Jerry. Yep.
Okay. So I guess here, this is the scenario. So my brother he works basically for a small little tiny place that doesn't offer insurance. So he gets his insurance on the marketplace because his wife, they don't offer spousal coverage. So she cannot get insurance for him. So he has to go to the private marketplace to get it. So he pays, for the chiropractor out of pocket, whatever, lots of money. So is there any way that he can do that pre-tax? Can she do the FSA and then submit for him for his costs out of pocket?
You know what, Cassie, I don't know. I don't know if for someone that's not covered under the plan, if you can submit medical expenses for them. I don't know if she can do that or not. I can research it and see if I can't find the answer to your question, but I don't know it off the top of my head. But I do know that if your brother had a health savings account, he would be able to do that for himself. But I don't know if she can do that if he's not covered under her plan. But I'll research that and get the answer to Jerry and have her get it to you if I can find it. I should be, I've got lots of resources. So let me see if I can find the answer to that question. And if I can't, I'll at least let Jerry know I've looked under every rock and I can or can't find it.
I think, Cassie, you're asking specifically about FSAs, right? Not about HSAs?
Either one. I'm just wondering, literally, this is for my brother. Okay. So because I've been trying, and this is an example. I mean, someone else asked me this about someone at work too, but we have the option to cover a spouse on a medical plan, but he doesn't have any insurance offered from anywhere. So he has to go to the marketplace.
So if he goes to the marketplace, Cassie, and sets up a health savings account, right? Then he'll have money in that account to get reimbursed for certain things.
So he would have, and so that's what I'm, so that's, I guess, is his best option would be to actually go for a high deductible plan so that he can have an FSA an HSA.
It might be his best option, but let me research and see if I can't see if he can't draw from his wife's account. I don't think so because he's not covered, but I don't know without looking.
Yeah.
And I don't want to say,
they don't offer it even for spouses. So that's why it's,
Right.
And I think I'm only just speaking from personal experience. Sorry, you can hear my kids yelling in the background. That I think it's probably whoever offers an FSA, whoever the financial institution is, probably has different policies, but legally, I don't think there's anything, that's your money. And so when you put in money into an FSA, into a flex spending account, you can use that for your dependents and your spouse. So for example, my spouse has insurance through his job. And if he has a $25 copay for his prescription, I can submit that for reimbursement from my FSA because we're a family.
Oh, so his wife could put money aside in her FSA and submit it for his medical cost.
Right. And you can only put in, up to, I think it's
$27.50.
$27.50. Yeah, but it goes up every year, Cassie.
Yeah, it's $27.50 next year.
It is indexed. But I would just to be doubly sure, I would ask her employer. I would have your sister ask her employer because the plan documents may be different for different plans.
Okay.
And ask her employer to say, I'm going to submit expenses on my FSA for my spouse. I just want to make sure it's all good.
Okay,
Yep.
good point.
Yep.
Yeah, let me know if you find anything out.
Okay, I will. I'll take a look and see if I see something.
Thank you so
Will do.
much.
Absolutely. Okay. All right. Well, everybody, thank you so much for your time and attention. We really appreciate it. And we hope to see you again soon. Jerry, thank you so much.
Thank you so much. Bye, everyone.
Thanks, Cindy.
Okay.